Good afternoon, everyone. We're just going to give it about 30 more seconds to a minute to make sure everyone is connected well, and then we'll go ahead and get started. Welcome. And while we're waiting, if you all who have joined already would like to just introduce yourselves in the chat and name and where you're from, that would be great. We tend to like to start our training sessions that way so that we know who's in the room. And welcome again for those of you who have just joined. Okay, I'm going to go ahead and get started. I am Dr. Dion Kokarapia, and I will serve as the moderator for today's Training Academy session entitled Community Wellness and Peer Support Training Academy. And this session will focus on trauma-informed practice in integrated settings. Next slide. Next slide. Just a quick disclaimer, just want everyone to know that this presentation was prepared for NTAC under a cooperative agreement between SAMHSA. All of the material that you will see today in this presentation, except those, of course, taken directly from copyrighted sources, is in the public domain and may be reproduced and copied without permission from SAMHSA or others. And this work has been supported by financial assistance through a cooperative agreement through SAMHSA. Next slide. And a security announcement. If for any reason there are any security issues during the course of this presentation, this session will immediately close, and then you all will receive a new link via separate email to rejoin the session. Next slide. And just like to show this slide that shows all of our wonderful partners who we all work together to bring all of these wonderful sessions and trainings to you all. These are our partners here on this slide. Just give you a second to take a look. Okay, next slide. And it's important for us to share our vision and services. And at NTAC, we believe that all children, youth, and families living with and impacted by mental health challenges will have access to resources and opportunities they need to thrive in a comprehensive and equitable system of care. Next slide. Some commonly asked questions. So, yes, you will receive a certificate of completion at the end of this training session. You will also receive a copy of this presentation as well as the recording. Next slide. We are offering continuing education hours for this presentation or training. And once you complete the evaluation survey, which you will receive at the conclusion of the training, you'll then be redirected to our CE hours form. So just be on the lookout for that upon completion of this training. Next slide. And today we are using a Q&A Zoom feature. And I just ask that if you have any questions for Dr. Kirk or any questions regarding the presentation, please use the Q&A Zoom function to ask your questions. Otherwise, there's so much going on in the chat box that we may miss some really important questions. So please use the Q&A feature for your questions and the chat box for everything else. Next slide. Now that brings us to today's presenter, and it is my privilege to introduce Dr. Carrie Kirk, who is an assistant professor in the departments of family medicine and psychiatry at Georgetown University School of Medicine, as well as MedStar Georgetown University Hospital. And Dr. Kirk also serves as the Director of Behavioral Health in the Department of Family Medicine and the Family Medicine Residency Program. Dr. Kirk's clinical practice, teaching, research, and advocacy are all grounded in her commitment to and passion for social justice and health equity. Dr. Kirk, it is my pleasure to welcome you to today's Training Academy session, and I'll turn it over to you.
Thank you so much, Dr. Coca Pia. I am so honored to be here today. Thank you all for inviting me to talk about this important topic that will ultimately impact approximately 70% of us in our adult lives. Thank you to your organization and to all of you who are spending your afternoon with us. So let's go ahead and jump right in and get started. So I know you all did a part one with Dr. Carter on some of the overlays and the basics of trauma. So today, what I'm going to do is I'm going to expand upon what she laid as a baseline and talk specifically about trauma-informed approaches and practices in an integrated setting. So all I essentially mean by an integrated setting is talking about teams and places who are places where teams are active. And there's some important things to consider with that. So if we're talking about trauma support in integrated settings, we have to start with what it means to have a trauma-informed approach when we're talking about trauma-informed care. There was a disclaimer earlier, but I want to reiterate that some of the topics that are discussed today could bring up thoughts or feelings or sensations that may be challenging to experience. Please feel free to excuse yourself if that happens at any time. And any of the activities we do that are group-based a little bit later, if you want to excuse yourself from those, feel free to do so, and your participation is voluntary and you can stop at any time. So what we're going to cover today, specifically, see if I can move this thing off my view. Sorry about that. So today's objectives, we're going to talk about post-traumatic stress and or more severe trauma, and then stressor-related trauma. And so I'm distinguishing from them for a number of reasons. We'll talk more specifically about that. We'll talk about some assumptions and principles of trauma-informed practice, and then we'll talk about practice and administration options or things to consider, either when you're practicing, when you're interacting on your team, and for leadership within your team, because it's important for leadership to have buy-in for trauma-informed practice. So for the who's and the whys, I think you all already dropped in the chat. I'm going to take a look here. Who you are. There's a lot of people from school-based facilities from Virginia. I see Colorado. I see Oregon. I see Texas. Oh, wow. You all are from all over. We have probation and parole. We have Puerto Rico. Wow. Welcome, welcome. Thank you all for joining me. If you all could, I would also like, while I'm going through these and welcoming you all from all over, could you all put, if you haven't already, put your role where you are and drop that in the chat? Sometimes that's really helpful in framing the discussion about who we are and where we come from, because it helps to know our why when we think about our role. So more people dropping in. We have case managers, service workers, school counselors, family advocate. We have parent educator. We have school-based therapists, lots of you all in schools. That's awesome. Service worker, school counselor, case manager again. All right, so lots of variability here. So we have from the full scope of practice in clinical practice to clinical practice in terms of support, as well as we have peer specialists. That's awesome. We'll talk about you specifically in a minute. Great. We have program director. We have some students in the house. Welcome, students. All right. Prevention coordinator, patient navigator, or parent navigator, I'm sorry. Awesome, awesome, awesome. Thank you all for sharing what you do and where you're coming from. And so I think the common consensus with all of you that are dropping your location and your roles in the chat is that we are a group that provides a service. We're a group that provides service to our community and service to those who we support. So it's even more important because we serve such a wide array of people that we are keeping in mind and being the most trauma-informed we could possibly be to ensure that our practices are as best as they can be when we're working, particularly in schools and the community, with people who might have experienced trauma or stressors in the past, and that we try to limit our limit the likelihood that we could re-traumatize them or things like that. So thank you all for sharing that. Okay, so I'm gonna breeze past this one a little bit about with the individual. I'm going to do both at the same time. Particularly, I know you all work with Dr. Carter for part one, for those of you who went to that talk. For those of you who are in the room now, if you could also drop in the chat, and I'll monitor that as well. What do you or what have you learned about trauma-informed care, or trauma-informed approaches is what it's called in some other places? Just seeing where we're at here. Feel free to drop it in the chat. Trauma educator for 15 years. That's awesome. Jody. Less about what did you do and more about what has happened to you. Absolutely. I don't have this in the resource section, but there is a book called What Happened to You that I find lovely for trauma approaches and trauma reading. What else? Anybody else want to share? What comes to mind when we think of trauma-informed care? Okay. So we got the importance of being trauma-informed in supportive housing contexts and how to approach difficult situations with more care. Absolutely. Learning and recovery is not linear. Absolutely. Assuming your clients may have been traumatized in the past. Absolutely. You all are right on top of it. Hopefully I'm able to teach you some things today. Meeting them where they're at. Yep. That is very important. Create safety, reduces re-traumatization. Often requires time-intensive therapy from a clinical perspective. Yep. And trauma's ability to influence likelihood to seek out healthcare. Yep. Trauma influences a lot of different things. Culture, humility, and responsiveness is needed. You all are awesome. Understanding connections between psychological scars and biological reactions. So the mind-body connection. Awesome, Shawnee. Awesome, awesome, awesome. So thank you all for that. So it sounds like you all have a good baseline. So a lot of you have been doing this trauma work for a long time. The talk today specifically goes over the trauma-informed or trauma approach within teams, informed by our basic knowledge of trauma, right? So, excuse me, within that, you all talked about some of the primary and secondary traumas and different kinds of trauma with Dr. Carter. So I won't review those again today, but just as a reminder, or for those who did not attend her talk, she listed the various types of trauma. So primary, secondary, an event that is likely to have psychological impact is secondary. The acute traumas, chronic traumas, and complex traumas are some of the things that she highlighted in her talk. So that's just like some context for what we're talking about today. And then basically, in addition to what she's saying, there's different definitions of trauma, but we know as we're anchoring in our talk today that trauma has a lasting adverse effect from some kind of stressful event that involved threat or danger. We talked about safety in the chat. So many people mentioned the safety of the person and making sure the context from where you're coming from is really important. Trauma can be emotionally dysregulating. It can impact worldview and relationships. So that came up in the chat too, and how people see themselves as a result of the trauma. We need to be important. It's important for us to be mindful of that. And one of the things as we're heading into trauma-informed approaches in integrated settings is, for simplification, talking about big T, little t, and complex T. So Dr. Carter talked about complex in hers, But big T, little t is in no way assigning a value or a numerical or quantitative relationship to a stressful experience. But for the ease of conversation, either in patient care or to people who do not do the work that you do, and they're not as clinically minded or they're not as community focused as you are, sometimes it can help to have a way to discuss or talk about these things that resonates better with people who don't have the same kind of minds like we do. And that's something we're going to talk a little bit about today. So again, big T, small t in no way is a quantity of the trauma or stressful experience. But what I'm talking about here are the things that we need to be mindful in integrated settings to make sure we're screening and assessing for, which we're going to talk about in the second half, as well as just being naturally mindful of who's on your team, what does your team bring to the table, who are you practicing with, who are you serving. A lot of you are in school, so what's happening with your students? Some of you are in clinical settings, what's happening with your clients or patients. And traditionally, the big T, as you see on the left, is more traditionally what we think of when we think of the larger trauma, right? So whether it's post-traumatic stress disorder or not, one of the kind of the items that would meet the criteria for trauma in the DSM or a sub-threshold category for trauma or stress-related disorder in the DSM, that's what we see on the left-hand side. So sexual abuse, physical or psychological violence, accidents, death, fire, those kind of things. And what we see on the right for small t is more so they could still be sub-threshold, but they're things that the regular people that don't do what we do and are not as mental health minded or mental wellness minded as we are, they might have a harder time connecting to these things on the right as things that are considered stressful and possibly traumatic experiences. The small T's are where trauma-informed care usually lives, particularly in a team-based setting, especially for teams that are serving the community. Because oftentimes, some of these things, this is just a handful of them, but some of these things are not considered by people who might have Googled the definition of what trauma is. They might not consider some of these things as stressful to the point of causing some kind of trauma on the individual. And so we get things like threats, humiliation, stalking is one that can be on here. That happens a lot with social media these days. Disturbed childhood, separations, divorce for children, and the partners who are going through the divorce. Miscarriages, fertility issues, or fertility journeys in and of itself with the ups and downs of those. Various bereavements, any type of professional or scholarly setback. Harassment is too, but some kind of setback or change to the course of what someone thought their life was going to be like. Those are the things that we want to consider, among many other things, to make sure that we're grasping with regard to what is happening on our teams and what's happening for the people that we serve. Okay. And again, here's some other examples, but then I'm inserting the complex trauma in here too. So when we think about complex trauma, we think about kind of repeated exposure to various threats to either one's life or livelihood. And we'd have multiple deployments, different forms of oppression, racism, poverty, any type of phobia, any type of repeated violence that may not actively come for the person, but still is a source of violence that they're exposed to. Anyone with chronic medical conditions and chronic health concerns where they repeatedly have to go to a hospital, they repeatedly have to have surgery or take medications that impact their body and their mind or their wellness overall. Witnessing those kind of things, that's also something to add to our lens when we're thinking of, all right, what kind of team am I on? Am I creating a safe enough space for these kind of conversations to be had? And even if I don't, or if someone doesn't reveal that they have some sort of big T, little t, or C trauma, are they safe enough to exist on the team without even having to know what's going on, right? And there's also levels of trauma experience, right? So we have At the very bottom, let's start there and work our way up. So we have individual trauma that impacts the person. And as we go up, we get broader and broader into community. So those of us who work in communities in large groups, it's really important for us to consider where you start at. So community trauma is at the top. And then that includes cultural trauma, racial trauma, any kind of generational trauma for a group or for a set of individuals. All of the things underneath it are also considered intensive traumas for us to be mindful of within our group. So family trauma, group trauma for anyone in particular, a group of students at schools, any particular community that constantly faces discrimination and harassment. All of those different things are things for us to consider when we're thinking about different levels of trauma and the experience of trauma when we're thinking about trauma-informed approaches. Here are some quick stats. This is what I mentioned earlier, that approximately 70% of adults will experience at least one traumatic event in their lifetime, which is a very high, a very significant number. And that includes anything from our perception that we think might be either traumatic or extremely stressful. It doesn't have to be PTSD to be considered traumatic or stressful. And so with that, about 70% of us will experience that. That's a lot of people. 1 in 13 people will develop PTSD, approximately, with the current statistics now. 20% of people who experience a traumatic event will develop PTSD. For reference, the prevalence of PTSD in the United States is equal to the total population of Texas. And as we know, Texas is actually bigger than some countries in the world. So there's a lot of clinicians in the room. I know there's some peer specialists in as well. I'm not going to go over in detail the criteria from the DSM-5, but I do want to highlight some of the points as we continue to highlight what are the areas that might come up amongst our team. So for the PTSD criteria, criterion A is the actual stressor, and only one of those has to be present. And that is the stressor that is a threat to life, or someone or watches or observes that, or a threat to life of someone else. There's direct exposure, there's witnessing. Only one of those kinds of things has to be present. Then we move on to intrusion symptoms, which are things like flashbacks, intrusive memories. And those of you who work in the schools, the children older than 6 may express their symptoms in repetitive play. And so when you're watching them, if they're expressing something or acting something out repeatedly that seems concerning to you, this is something to be mindful of. Nightmares are also an example of this. Those are the nightmares and flashbacks are the most common ones we hear sometimes. And then 1 is required for that criteria. Criterion C is avoidance. And there's an avoidance to either the thoughts or feelings related to the trauma or the external reminders, and only 1 of those is required. We have negative alterations in cognitions and mood. 2 of these is required, right? So there's inability to recall the traumatic event, so kind of some blackout memory there. Negative beliefs about oneself or the world, or their worldview is changed dramatically. There's fears, or there's consistent sense of anger, guilt, or shame. I worked in the VA for a while, and the criterion D area was where I spent a lot of my time with the veterans that I worked with, and was honored to do so. Feeling alienated from others, things like that. So there's 2 of those that are required. And then alterations in arousal and reactivity, 2 of those are required. So that's where you get hypervigilance and sleep disturbance, which are 2 of the most common that I see in clinic. I'm not sure kind of how it works for you all. And there's a duration. There's the functional significance or the functional impairment, which we have for most of our larger mental health criteria. And then it can't be due to something else. The post-traumatic stress disorder can't be due to something other than the actual events that occurred. There are the specializations or the specifications that we see. So there's a dissociative one, the depersonalization, derealization, and delayed specification. So I know a lot of you in here have a lot of trauma education, so I won't go into detail on these. I just wanted to, again, set the foundation while we're talking about the different levels of trauma. This is a quick acronym that I often use with the residents that I work with in the primary care clinic that I direct. It's from the AAFP, and it's dreams is the mnemonic that they use for screening patients. And this is also something that on your teams you can think about in terms of incorporating this as part of your trauma assessment as well. And we'll get to assessment and screening in a little bit. But detachment, re-experiencing the events had an emotional effect. There's avoidance present. It's a month in duration, and there's sympathetic hyperactivity or hypervigilance. And that tends to, our residents really like this because they're able to, if they're talking to someone and they start hearing those cues and signs, this really helps them bring the information to the forefront, and they use it as a little checklist for them when they're in the room with the patients that they serve. And I'm in a medical setting, so I do use patient and client are not as much interchangeable in that setting. So I just want to preface by saying that. And then as I know you all did the ACEs survey with Dr. Carter, so I won't have you do that again. But for those of you who did do that and can recall the information that you put on there, or your score or whatever else it is that was important to you from that, thank you so much for doing that. For those of you who haven't seen ACEs, it's Adverse Childhood Experiences. And these are potentially traumatic events that occur in a child's life. And when you do this as an adult, you're kind of pulling forward what those experiences were for you. And that's how we get at that 70% of adults will have a trauma at some point in their life. And these are some examples of things that are included in the adverse childhood experiences discussion. And so physical abuse, mental illness of a parent or a caregiver, parental substance abuse, if they were exposed to suicide or death, things like that. Those are all ACEs. So when we're practicing, a lot of you are in clinical or community service driven places. Dr. Carter doing the ACEs survey with you was kind of an example of something, one of the screeners that we would use for trauma-informed approaches to get a baseline of where people are at. This is one of the most common screeners that are used, and it can be used whether it's your practice, you can use it from an administrative standpoint with your teams, just being mindful that there needs to be some kind of trauma support available if this is used or utilized in any kind of way. Some other things to keep an eye out for those of us who are more community facing and not quite as clinical, are people telling you they were exposed to violence. Are they telling you that they had abrupt or repeated exposures to some kind of stressor? Do they have frequent unmet needs? And then a new one that a lot of people, it's not new, but a lot of people don't think about it in this way, is prolonged grief. Our community and our mental health community, even as a whole, our general community in the United States doesn't handle grief as well as many of us would hope. And sometimes not being able to hold or handle grief, or grief making others uncomfortable, ends up making or kind of adjusting to grief. It makes it difficult for the people who experience it. And on top of experiencing the loss, the prolonging of the grief sometimes can be a byproduct of not receiving enough support along the way, or just experiencing such an immense loss that there isn't any kind of support for the immediate time frame that's going to help the person. So just keeping an eye on that lens of what that means for others around you as well. Okay. So now that we've set some of the foundation of some of the things that we're going to talk about today, I want you all to do a quick reflection and thinking about something that your younger self wanted or needed. And we're going to do some breakout rooms for this. So you have the baseline education. It doesn't have to be something stressful or traumatic, but it should be something that we're going to tie that into the discussion about what we're about to talk about with trauma-informed approaches and integrated settings. So I'd like you all to spend a few minutes thinking about a specific event from your younger self. So between the ages of 5 and 17, roughly, it could be just your younger self, whatever that is for you. And it should include a memory of not getting or experiencing something that you needed or wanted. It could be with school, a caregiver, a friend, or a loved one, whatever it is. So I will share first. My example is when I was 5 years old, I did not get what I used to call Barbie keys and Barbie car. It was one line. There was no breath. There was no nothing. Barbie keys, Barbie car. I didn't even like Barbie. I just wanted the Power Wheel, is what it's called, but I called it Barbie keys, Barbie car. I thought I was going to get it for Christmas when I was 5. And I was so excited for it. I just knew I was going to get it. And I woke up Christmas morning and did not have it. And that stuck with me for quite some time. And so what I want you all to do is a memory, something like that. It could be funny, it could be more kind of lighthearted, or any of those kind of things. I want you to think of these 6 things. So what were you wearing? What were the sights, sounds, and smells? I remember the Christmas lights fluttering on the tree, and there was no Barbie keys, Barbie car. Where did you feel the sensation that you didn't get what you want or needed? My stomach dropped when I didn't see the car. How did you feel afterwards? I was disappointed. My little heart was crushed. And what did you immediately do following? I pouted, and then I got reprimanded because I had all these other gifts under the tree, and my parents were upset that I was pouting because I wanted this one specific thing, and they got me all these other things. And how often do you think about that event today? Rarely, but whenever it comes up, it's a joke amongst my older. I'm the youngest, and it's a joke amongst my siblings. It comes up every Christmas that you remember when you didn't get that Barbie keys and Barbie car, and it's kind of like a thing that they reinforce. So that's what I would like you to do in your rooms. So if somebody could take a picture so you'll have the review questions with you. And I think there's a way for me to drop these in the chat too. I can do that once we split out. But go ahead and go to your rooms. And you'll have a few minutes to work on this or talk through this amongst your groups. Joanne. All right. Welcome back, everybody.
Hi,
Hello.
I joined late, was on another call, and I'm so glad I'm here. This is so much fun. Thank you.
You're
I'm I'm
welcome.
I'm Tila. Thank you.
Hi, Tila. Thank you for joining us.
Mhm.
Okay, as people are trickling back into the room, in the interest of time, I would like to keep us moving along. Let's debrief this. Does anyone want to, I shared my Power Reel story. Does anyone want to share something, kind of a really quick summary maybe of what their group talked about, the things that our little self or younger self wanted or needed? We can take maybe 2 or 3. Or less, if no one wants to share, that's okay.
Um, this is Selena.
Hi,
Uh,
Selena.
so I'm hoping not taking anyone's space. It was for our group. It it was the difference. So I'm trying to think of how you said be mindful of sharing a memory that is like de-stressing. That was definitely hard. Because memories, for some reason, the memories that pop up automatically are something that's trauma, right?
Yes.
I think that oh my goodness, I forgot her name. One of the ladies were able to find something, and it was great. And then me, I couldn't find anything that was outside of trauma. And then one of the other ladies automatically went to something that had hurt her. And
Mm-hmm.
so it was like different how memories pop up
Yep.
for us individually, and how we how certain things stand out to us and
Yes.
follows us all the way through. And so I could not think of anything that would be distressing in that time of my life. I would really have to sit down and
And think about
work
it
it
longer than
out.
the 30 seconds that I gave you. I totally
Yeah.
understand.
And
Um,
so
Thank
that's
you
how
so
our group.
much
Thank you.
for sharing that, Selena. And thank you to your group mates who also contributed to that discussion. You're hitting the one of the bigger points or the larger points of this discussion, in that for some people the memory is going to go in a direction that's like, oh, this was that one thing that I really didn't get, but it isn't that big of a deal to me now. For other people, your memory is gonna, you know exactly what you didn't want or you didn't get or what you needed and weren't able to obtain, and by no fault of your own when you were a child. Your memories are gonna go in that direction, just how the prompt was worded, right? The point of this exercise was for us to see the differences in those directions and some of those areas or some of those places that our group members were going to go, because that is how an integrated team will be. We will all have different approaches, different thoughts, different memories, different life experiences, different things that bring out the joyful memories for us, different things that bring out the not so great memories for us. We're all very different. And the ways in which we kind of think about those things when we're in a group is really, really important. So thank you, Selena. You hit the nail on the head. That's particularly why I do this exercise. And Melissa is sharing, I was really excited to go to camp and learn to ride a horse. When we had our first lesson, the horse got spooked and threw me off. Oh, I'm so sorry to hear that. It's been 30 years, but I still remember the feeling of falling through the air, the drop feeling. I know exactly what you're talking about. And sight of the barbed wire fence. Oh, wow. Okay. So that's a memory that has multiple sensations. She's looking at something in 1 minute and she's in the air the next, and that sensation of your mind trying to figure out where or how this is going to end, or how you're going to hit the ground or not. That's a very vivid memory. Thank you. I can see it in my mind. Thank you, Melissa, for sharing that. Anybody else want to share? All right. Well, again, thank you all for participating in that. For those of you who were able to do it and share those experiences for yourself. And hopefully at some point, either if you've done it now or in the future, you've been able to do something for yourself that is a good support for your little self, for your child and late and adolescent self, as you are continuing to progress through adulthood. All right, let's pick up where we left off. So I know there's a lot of folks who were not able to do the breakout rooms. So we can do this one in a couple of different ways. We can stay in the main room and you all can unmute to do this one, or drop in the chat to answer some of the other questions. That might be more efficient for us. Okay, so next question, along the lines of caring for your younger self, what do you do now? How do you best care for yourself? A lot of you mentioned you're in service fields, you're in schools, you're in the community, you're doing some kind of service to the homeless. You all are doing things that requires a lot of output from you. It requires a lot of energy, it requires a lot of engagement, and you're doing it for whatever reason, for whatever your why is. But everything that you're doing, everybody that's in this room deserves to care for themselves in whatever way you need. And on the left is some specific ways that self-care is, or care for self is, a part of kind of our larger framing. But when you're thinking about that, whether it's for your younger self or now, what are some ways that you best care for yourself, that you know that you go to? And you all can drop in the chat, you can unmute. Joanne, we won't do breakouts for this one since so many people couldn't join them.
Okay. For me, I think this is Selena again. The spiritual, when we're looking at the dimensions of wellness, spiritual and environmental are very important to me, because I'm I'm a peer support specialist. I'm in
Mm-hmm.
long-term recovery, and I work in the NICU. So I work with moms that have babies that are exposed, and I help them. And it is very challenging. I'm
Mm-hmm.
that mama myself, and so it's a lot of, because it's not just I'm here for the mama, I'm here for the baby, and I'm here for
Yep.
the family, and I'm here, and it's just like, here's all of my cup, and so I have to, I've experienced like burnout and what do they call it? Compassion fatigue. I don't
Compassion
know if
fatigue. Yep.
that, I don't know. I feel, and I have definitely had to take a step back and look at my mental health and how not giving can affect, I mean, how giving so much and not taking care of yourself can affect like your whole health. And so
Mm-hmm.
those two things are very important to me.
Absolutely. Thank you for sharing that. And again, as we pour out from our cup, we have to make sure we have ways to pour back in or add more substance to either the meal or pour back into the cup. So thank you so much for sharing that. We have some other things in the chat. We have sleep and exercise, try to eat well. Sarah reads. Jody practices yoga. And which fills numerous dimensions: service, financial, relational, emotional, and spiritual. Awesome. Thank you for sharing that. Brenda goes out and walks to ensure she gets enough sleep. There's another walk. Lewis walks as well. Jackie does spiritual and attitudinal care. Caitlin plays with her daughter. Julie does therapy and exercise, talks to her friends, junk journaling, running, weightlifting, dancing, mindfulness practices, connecting with others, breathing exercises. Physical, environmental is important to Kiera. Hydration, journaling, therapy, travel. Scheduling on the calendar. I get a message every 2 weeks and it's on my calendar as office cleaning. Using the calendar trick, making sure you're busy. Others know you're busy, but it's self-care that's scheduled. I love that, Barbara. Church. Let's see. Looks like rest is in here. Nice meal for Kristen. Spiritual, physical, and relational. Trying to limit mindless scrolling. You all are doing some great things here. Running, cycling, so physical activity. I love to hear that. Therapy, music, showers, religion, God first, journaling. Great. You all are doing a lot of different things here. I love that. Unplugging from social media, leave work at work. I wish more of us could do that. And overall, you all are listing a bunch of different things in the different domains that we all need to think about. Whichever ones are best for you are the ones that are best for you. Those are the ones that if there is a stressful experience within the integrated settings that we need to be mindful of. And then also, this is a form of assessment that you can do for those of you who care for others with regard to what would fill their cup up in terms of your work with them and how would that best work for them. I'm going to skip over this one for now because I'm going to come back to it at the end. So I want to save some time. So for now, let's go into the specifics of trauma-informed care and trauma-informed approaches in integrated spaces. And so if we're thinking about that more broadly, the SAMHSA model, as this talk is supported by, the SAMHSA model is as follows in terms of what is trauma-informed care. We have the 3 E's of trauma, the 4 key assumptions, the 6 key principles, and the 10 implementation domains. I'm not going to go in depth in all of these today, but I do want to share some of the things in the different areas for you all to take back to your organizations, take back to where you are, take back to your general practice, take back to your self-care. Any place you want to take some of these, you can take this information with you and use it accordingly. Usually when I give or talk in this area or talk in this domain, I usually break down the 3 E's and 4 R's as something that we practice with. So for those of you who are peer support specialists, therapists, counselors, all those important, very, very important jobs, the 3 E's and the 4 R's are usually the areas that we practice with. So from a clinical, subclinical, non-clinical, but patient or person first practice. The two on the right, so the 6 key principles, the 10 implementation domains, this is usually when we think about kind of what the talk is about. So amplifying trauma-informed approaches and integrated spaces. And so the 6 key principles are in relation to the team that's built, and the 10 implementation domains are in relation usually to the overarching structure of an organization and how the structure and the system, the organizational system, implements trauma-informed approaches. Whereas the 3 E's and 4 R's are definitely part of administration too. It's part of how you know who's on your team. Sometimes an easier way to break these two down is by practice on the left and administration on the right. As we go through these, you'll see the different areas or different things that could be applicable to either. So either your practice or your role on a team where you are, or your role as a leader where you are. Because many of we in this service field, we do so well at what we do. We're often plucked into leadership roles. And any of this from the 3, 4, 6, or 10 will be helpful for us going forward. So let's start with the 3 E's. So many of you've been in trauma for a long time. So when we think about the 3 E's of trauma, we're thinking about events. So the circumstances of the trauma or stressful experience. We're thinking about the actual experience in and of itself. And so the person is the person who determines whether or not the experience was traumatic or stressful. I say this to the residents that I work with all the time. They'll come back to me. They met with a patient for 15 minutes, and they'll come back in consultation, and they'll be like, Dr. Kirk, this patient had a trauma in 2017, and I really think that we should do X, Y, or Z for them. And I'm like, okay, well, what was the trauma that you're referencing? Well, they were in a car accident. And I'll ask them more questions, and then I will say, well, what did they say about trauma? Did they say this was a traumatic experience? Well, no, I just think personally that a car accident would be traumatic. And then we have to have that long discussion about the provider ascribing a trauma to somebody who didn't say themselves that it was a trauma. And so the one as a big part or practice in trauma-informed approaches is what I'm teaching where I am clinically, is that the individual gets to say. And that's a big part of autonomy. That's a big part of growth. That's a big part of kind of expansion as the person grows around whatever the experience was, they get the say so. And that's an important thing to hold. Effects of the trauma include anything that we can think of from almost from all those self-care domains, right? Physical, social, emotional, or spiritual consequences that may have come from a trauma or stressful experience. When we think about all these 3 E's together, this is kind of the baseline entry point to when we're thinking about trauma-informed care. So I gave an example of what my trauma-informed approach is when working with a learner and how I would address that. And then with regard to events, we're often thinking about, well, what happened? So we talked about at the very beginning of the chat that what happened to you versus what's wrong with you is part of events. And then effects can be whatever they are, wherever they are, whatever they come from. The 4 R's are, I won't read all these in detail, but what I want you all to get out of the 4 R's is that whether it's a practice or administration standpoint, having us all think about how widespread trauma is and how it's up to us in whatever system we're in or that we belong to be mindful of these 4 R's. And so with realization, it's our duty to recognize that trauma exists for many, many people, and the significant stressors exist, and we need to be mindful of that in and around our spaces, and how we navigate our social and work settings makes a difference there. And then adding on top of realization, we have recognition, and that's us knowing and improving our tools with regard to how to spot that among our team. And the best way to do this is through screening and assessment. So you can do kind of abstract things like I was doing earlier to get at a difference of how people think and what comes up for them. There's very specific, there's work-based trauma screening assessments. There's that ACEs questionnaire that we talked about at the beginning. There's a lot of evidence-based tools to screen and assess for for what is happening amongst your team. That's really, really important. If you're really serious about a trauma-informed approach, screening and assessment is almost mandatory, absolutely mandatory. And then training and support of leadership, and how once you get the data, right? So once you do the screening and assessment, you have to do something with it. You can't just screen an assessment to check it off and check off a box and then not do anything with it. So that's where supervision and workforce development comes in, because we have to be hiring leaders and putting leaders in position that know how to uphold or support whatever is coming out of the assessments. And an employee assistance, some places have employee assistance programs, things like that. That's really important too. For response, after the screening assessment is done, we keep in mind that approximately 70% of all adults is going to carry something with them that's going to be important to recognize. That's the do something piece. So if once the screening assessment is done and it's time to consider what is the makeup of our integrated team? What do we do? What's the do something? And then how do we continuously support our team? And if it's you and a couple people, and it may not be a big team, but you're serving the community, how do we best serve our community after we do these kinds of assessments? So it goes either way, whether you're practice or whether you're administration or whether you're considering a combination of both. And then, as we talked about earlier too, resist re-traumatization at all, as much as you can. And that can be harder for organizations, because when we're in a lot of the models we're in, so the system that values money and dollars and the kind of the capitalistic spaces where sometimes numbers are valued over people, sometimes the policies and practices and interventions that are in place, they're not the best for your team wellness, right? And so if there's policies or practices in place that don't necessarily support the resisting re-traumatization, that's something that should be modified, whether that's your clinical practice or whether from an organizational standpoint, if you have different things in place that can be traumatizing to some people. And that could be things as simple as changing up a job description, where someone was like, all right, this is what I'm doing, and then the job description changes without communication. Abrupt changes that aren't explained but that impact wellness, leave policies, things like that. Like those are the kind of things that people don't realize can be traumatizing when they're adjusted or changed. And that's a big thing to consider. And then from a practice standpoint, usually mental health organizations ethically, we have to have a lot more support around this, but then some organizations now are either tech-based or different things that we work for that might not be mental health-based, that we still have to consider trying our best to resist re-traumatizing. And then this is on the right, this is a quote from SAMHSA, that a program or organization or system that is trauma-informed realizes that the widespread impact of trauma, recognizes the signs, and then responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So there can be unintended consequences of things, but it's impact over intent, right? So if there's an unintended consequence of something and there is no response, the impact is going to be different than if there is an active attempt to actively resist re-traumatization. So next we have the 6 principles of trauma-informed care. And so I'm going to read you an organizational approach that a company used to try to ensure that they were maximizing their trauma-informed care across all of these domains. So I'll let you read on the slide what the domains are. And then this is directly from a company. They were trying. This wasn't perfect, and we edited this out specifically, but this is where they started from. So at our company, safety will include trained leaders creating a culture of belonging and acceptance with a balance of execution of program goals and support for our staff. There's a culture of openness and regular open forums via staff meetings or other places where people are allowed and encouraged to raise concerns and share triumphs and highlights. So I was encouraging them, everything shouldn't be about a problem. You have to have a balance of both. If there are issues to address, you also have to bring in things to highlight and recognize your staff and your team. This, in turn, assists with creating trust and trustworthiness and transparency by where team members are not afraid to speak up. Within the team, there are identified peer supports or mediators who are trained and knowledgeable about limits of confidentiality and protecting anonymity, but that also have the power to raise concerns of the collective voice. These specialists can collaborate with one another or work with the leadership team to address raised concerns or enhance or highlight the things that are unanimously working. There can also be meetings dedicated to group problem solving, where everyone who wants input can have it. This leads to empowerment of internal voices, team building, and team bonding, which I separated out for them intentionally. Team building and team bonding are two different things, which further assists with others feeling seen and heard. And lastly, this team strives to ensure that our makeup is as diverse as possible across many different areas of diversity and belonging, so that as few people as possible feel alone, isolated, or left out. This team prioritizes safe spaces to share and for others to learn about each other, so that areas of power, oppression, and prior traumas or resistance can eventually be highlighted and addressed in policy and procedures within the group. This resulting team is a team that actively practices a trauma-informed approach. So that was kind of a mission statement that I worked on with a smaller organization to ensure that as they were trying to shift more towards a trauma-informed approach, that they had a vision and an idea of what they wanted to do. And they took from each of these domains, and then from each domain, they had an implementation step, which is where that mission came from. So that's kind of an example of how you would integrate all these things together. Okay, so the next we have the 10 domains of implementation. So I'm going to focus on the 3 highlighted in red there, but because this could be a whole nother talk about all the different things, because this is in and of itself is a large domain by itself for trauma-informed approaches. But as we look at these, this comes from many different angles and almost all the angles of what it takes to run an organization in an integrated space. So again, remember, for those of you who joined us late, integrated simply just means, in this context, a team. So an environment where you have a team, and most of us are in the mental health space. So an environment where there's mental health professionals of peer support, therapists, counselors, all that included. There's a team that works together to ensure that as a team, we're doing trauma-informed approaches actively, and for the people who we serve, we're also keeping in mind with that dual consciousness that we're also still trying to be mindful of trauma-informed approaches that way.
Dr. Kirk,
Yes.
one quick question, if I may.
Yep.
There's a question in the Q&A regarding the workplace mission statement that you just shared.
Yep.
And the attendee is wondering if that can be shared.
Sure. I can share it with you or Joanne on the back end, and we can circulate that. Was there a specific question about it?
No, just wondering if you would be willing to share it.
Sure. Yep,
They
I can
think
share it.
that the breakdown was wonderful.
Yep.
Okay.
So just for some context on that, sorry, I didn't give you that earlier. This is a small organization that wanted to ensure that they were doing or thinking more mindfully about trauma-informed approaches and practices, and they didn't quite know where to start. And so we used the SAMHSA model, as I'm doing today, and we went through and as we discussed, so I did a bunch of steps with them, and as we got to the point of, okay, so what do you actually want to do, and how do we make that trauma informed? We stumbled upon the mission statement, and the mission statement had to have not only the things that you're committing to in each domain, or each of the 6 steps. It also had to have action-based items in each that if I were to come back and do a screening and an assessment of the staff, that I could assess whether or not the staff felt like these things were happening, and the mission statement was open to everyone on the team, so that they can see kind of what was happening and how that went forward. Awesome question. Thank you. Dr. Kokapi, was there another one?
No, that's it.
Okay.
Thank you.
You're welcome. Sorry, 1 second. Now I gotta find where the slide was. Okay, we got it, I think. Oh, I don't think it's that one. I apologize. There are too many tabs open. Okay, I think we have it now. All right. So we were down here. All right. So I combined governance. Can everybody see this? Just want to make sure you all are seeing the right thing.
Yeah.
Joanne, can you see this?
Yes, we can see it.
Okay, great. Thank you. I combined governance and leadership training and workforce development on this one because these 10 ingredients can they come from all those different areas. But these are some things to consider from a leadership perspective, from a training perspective, from your team building perspectives. Many of these things are applicable to all those areas. So communication is key in trauma-informed approaches because how well you communicate makes a big difference. Staff training, things like screening, which we already talked about. And then also making sure that as you are expanding your teams, that you're including people and training people appropriately as they're working within your system. So that kind of goes through all the layers there. This slide, I'm going to skip through the ones that look like this because these are all, you're going to get these slides. Joanne's going to send them to you. But these from SAMHSA, these are all questions to ask your team if you're truly thinking about a trauma-informed approach. And that this step is one of the steps I took to get to that mission statement, to have the teams walk through and think through some of these things together. And there's these sets of questions exist for all the 10 domains of implementation in the SAMHSA model. So engagement and involvement is a pretty particular one because if you don't have engagement and involvement, you don't know what's happening on your team. If you don't know what's happening on your team, or if you don't know what's happening with those that you serve, it's very hard to have a trauma-informed approach because you're either guessing or you just don't know. And if you don't know, then you don't know how to help. If you're guessing, then you might guess wrong, right? So the engagement is really, really important. So at the bottom, again, you can see some of those questions to ask yourself or ask your team as your team building on in an integrated setting. And then across the top are the specifics of engagement and involvement that are recommended. So making sure that there's outreach, so providing information about service plans. And then from a team perspective, outreach could be leadership, providing effective communication to the teams, consultation, so obtaining input via interviews, surveys, and reviewing service plans, involvement, designing service plans and collaboration, and partnership. So this can come from a number of different angles, but usually it means that multiple people who have a vested interest in whatever the team is have a sense of partnership and belonging, and not just bodies. They're not just employees, they're not just staff, they're not just whatever. They're actively partnering in the work that happens in the particular setting that you're in. And this one is really, really important to trauma-informed spaces too. And you cannot have effective engagement or involvement without having psychological safety or promoting psychological safety. And so on this slide, you see a few different things. It goes from kind of left to right, top to bottom. But key elements of psychological safety are really, really important for you to be able to get the information and the buy-in with regard to setting up a trauma-informed approach. Because if you don't have that, you won't be able to get what you need, right? So from a workplace standpoint, priority number one is inclusion safety. So making sure that others feel included and safe. Two is the actual safety part of the inclusion. So now that someone feels included, are they comfortable? Are they heard when they speak? Are they included in different things? Contributor safety. So as the different things unfold for a company or a practice or a service agency, what's happening to the people who are contributing to the organization? Are they penalized for certain things? Are they penalized for speaking up? Are they penalized for raising concerns? That should never be an issue if you want true psychological safety. And then challenger safety. Now that you're fully submerged into a team, you can now challenge the way the team works and brainstorm ideas as a part of the team, right? So anyone raising a challenge, that's not room for penalty. That's actually an area of growth if it's used in an appropriate way. And so all of these kind of things, all of these things together are key psychological safety tips for an actual integrated team to be mindful of from a workplace perspective. Now, this one is from a leadership perspective. And so whether you are a leader now, whether you're aspiring to leadership, and most of us are leaders, whether you think you are or not, in your respective organizations, this is a way to possibly think about how your engagement and involvement from a trauma-informed approach affects you, or how you can roll some of these things out. So role model how to handle failure, right? And sometimes it takes a little bit of vulnerability, but if something happens that's not quite right, it's okay to name that. And it's okay to say that and admit to a mistake, and then it'll help everybody learn from it. Evaluate current leadership style, right? So there is leadership and there's management. Those are two very different things. So a leader is someone that people look to, desire to follow. There's active learning in leadership to try to be a better leader. It's kind of like being an athlete. There's something that's always going to be growing and evolving within leadership. A manager dots I's, crosses T's, counts the beans, and then sets the agenda based on the beans and the I's and the T's. That's a manager. And it's usually where that difference of leadership from a leadership style to a manager, it's the difference there is often where a lot of trauma on the job happens, where there's more managers than there are leaders, and it's very difficult to grow a team that way. And so being mindful of our leadership styles and how there's multiple different kinds of leadership styles, but all of it includes psychological safety. The best leaders include psychological safety in their practice. Avoid blaming and negative language, and include the team in small or big decisions. So these are some things broadly to think about from all of our perspectives, but for sure from a leadership approach as the organization is building and integrating. So a lot of you are in settings where you have different members on your team. And so these are still things to think about regardless whether you're in a leadership position or not, because these can still be things that are implemented wherever you're working on your team. And you don't have to be a leader to bring these things to the table. And this is another set of questions to ask from a trauma-informed approach for policy. I think so we did these kind of in this way so that you all could see them. This is questions to ask from the cross-sector collaboration, which is one of the 10 domains, the physical environment, which is one of the 10 domains, screening, assessment, and treatment services, which is one of the 10 domains. Again, you all are going to get these slides. Progress monitoring and quality assurance questions, financing and evaluation. And now, which brings us to this point. So knowing what you know now, what are some ways that you can enhance safe communities within your team? So you all can unmute for this one. You can drop things in the chat if you want to, but you can unmute so we can kind of use the discussion space for this one. So again, Joanne, just for the sake of time, we'll do open discussion as opposed to breakout rooms.
Okay.
So knowing what you know now, in the trauma-informed approach space, what are some ways that you can enhance safe communities within your team?
I think the psychological safety is a big thing, because there's a lot of people in my organization and we don't have that feeling of safety.
Mm-hmm. Yep. And if you don't have that feeling, if you don't personally have it, the likelihood that others don't personally have it is very high. And the likelihood that not feeling safe prevents your peak performance as a team, it prevents your peak performance as an individual, that likelihood is also high as well. And so feeling safe, it calms your nervous system, it calms you down, it allows you to think clearly. There's so many other things there's many clinicians in here. We could pull out a long laundry list of what it means to feel safe. And sometimes the organizations we're in forget that safety is a critical foundation to anything that you want to do. And it's inextricably connected to making sure that we're reducing reducing the likelihood that we're traumatizing our team or creating a lot of unnecessary stress amongst our team. So it is very, very big. So thank you for sharing that. Anyone else want to share?
May I just add to the point of psychological safety and a good concept that I've learned?
Yeah.
Just kind of pulling from what you had just mentioned too about leaders showing vulnerability and being really transparent about when failures happen. My boss does a really good job of that, and so I've followed suit for my team. It just brings a real human aspect, and kind of like you were saying earlier, brings that psychological safety into your team, knowing that they can make mistakes, they can fail, and it's not going to end up in discipline or shame or anything like that. We're all learning, we're all trying different methods, and it just really promotes that, hey, we're all in this together. It's okay if we don't have all the answers. And so I would just encourage everyone to really start, looking at ways that they can incorporate that into any leadership styles.
Absolutely. So the vulnerability aspect, the modeling is in there from what I'm hearing. I'm hearing a collective engagement that your supervisor does. And within all that modeling, you're able to model it in other places for yourself. So that is effective leadership. And I don't know whether your boss knows it or not. That is as one of the ways to ensure that your boss is following a trauma-informed approach, or at least one of the aspects of it. So that's great. Anyone else want to share either on that question or on psychological safety? Okay, well, in the interest of time, I do want to review a framework with everybody, and then we can wrap up and open for questions. And I think Dr. Coca Apia needs to talk a little bit more before we wrap up. There is a framework. Some of you might be familiar with this, some of you might not be. It's called liberation psychology, and it's in and of itself, it's one of the emerging evidence-based ways to address trauma for those of us who work in a clinical setting. If you are not a clinician, you can still use this amongst your teams and wherever you use for whatever you do in your service organization. And essentially, the long and short of it, without going into the nerdy, brainy details, we have trauma that many of us have experienced, and then we have restoration. And we have somewhere in between that trauma is how we get to restoration. And what we're finding is that if we're able to be more collectivist in our thinking and approaches, it can often lead to restoration, which can diminish the effects or lessen the effects of the trauma on the individual by way of community. And so within that, you can think of accessing cultural resources, and culture has a large definition, means a number of different things. Spirituality and religion, which we talked about in our self-care approaches. So many of you are already doing some of that. One of the things that's not talked about enough is the aspect of community care. Community care can happen anywhere there is a community that you rely on, can trust, and depend on. So if that is your workspace, congratulations, you were on a wonderful team and you are one of very few people that has that in their workspace. If it's not your workspace, it's important from a standpoint of going through the 4 R's and the six steps and then the 10 principles. It's important as you're thinking through those things that is something to potentially either connect the people you service to or yourselves to at any point in time to ensure that you're kind of balancing somewhere in between, heading toward the right side of the diagram on the left. Expressing yourself creatively and then using resistance strategies is also part of liberation and an approach to managing or addressing trauma. But in general, that community care one is really, really big. So either finding or connecting to a community that is safe, that you trust, that you value, that values you, that lifts you up, that supports you. This is something I would encourage you all to take back to wherever you are. And the framework is called liberation psychology. Dr. Tama Davis Bryan is one of the scholars that works in this area. And so in this space, as we talked about the Samson model, we talked about some of those other things. This is also something you all can consider moving forward in terms of how you're thinking and navigating different aspects of trauma-informed approaches. And so I will skip over that for the sake of time. You all will get these resources. These are some books and some workbooks and just trauma steps that you all can go through on your own. I can also give the other, that mission statement to Joanne. Here are some other things from SAMHSA that I use in the references. And that is all that I have. If there's any other questions, I'd be happy to answer those. And I know that Dr. Coca Pia has to say some other things to you all as well. So thank you again for having me. My contact information is here on the slide. And as we're kind of exiting out of here, I will say that caring for myself is not self-indulgence, it is self-preservation. And so as we do this work, we cannot do this work without preserving of self, because we're giving so much of ourselves to other people. And so if we're not whole and preserved, then we're going to give fractions of ourselves to the others that depend on us for our care and support. And it's really important for us to consider that context. So thank you, everybody.
Thank you so much, Dr. Kirk, for this wonderful training session. We have a few minutes for questions or comments. I don't see anything in the Q&A box, but if anyone has a question or comment and you'd like to unmute and ask Dr. Kurt, we do have a couple minutes to take maybe a couple questions, or you can feel free to put anything in the chat box as well. And I see a lot of thank yous in there for you, Dr. Kirk.
You all are very welcome. Thank you again for having me.
I'll just see if anyone has any questions or comments. And then if not, I will share a few wrap-up slides and just check this again. No questions here. Okay. Okay. I will go ahead and wrap us up. Would you mind, the slides are at the end of that presentation. Would you mind sharing those slides again?
Oh, yes.
Just a few reminders from the beginning. We're going to have another Training Academy session on February 6th from 10 to 12 p.m. Pacific, and that Training Academy session will focus on facilitating culturally responsive discussions about psychotropic medications. Next slide. Please join us for that session if you all are available. Again, after today's session, you will receive a certificate of completion as well as a copy of the presentation. And I see that some of you have asked for that in the chat box as well as a copy of the recording. So you will receive all three of these resources. Next slide, please. And then again, it's really important for us to hear from you all about today's session by completing the survey that you will receive once we conclude. And your time and your feedback are greatly appreciated. And we use that information to continue to bring these free resources to you all. So please share if there are other topics that you would be interested in learning about. If you want to hear more about this topic, whatever you'd like to share, just please feel free to include that in the survey when you complete it. Next slide. And again, just want to send another reminder about the continuing education hours. You'll have access to that form once you complete the evaluation survey. Next slide. And please stay connected with us at INTAC, and here are multiple ways in which you can connect with us to ask questions, to request additional resources and trainings, or to just provide comments about the sessions that you've already attended. But multiple ways to stay in touch. Please feel free to reach out to us at any time. Next slide. There may be a couple more slides. And This is our final slide about SAMHSA's mission. And again, Dr. Kirk, we truly appreciate you taking the time to bring forth a very thoughtful, insightful, and informative follow-up session on trauma-informed care. I learned a lot. I'm sure our attendees learned a lot, and we just truly appreciate your time and your expertise in this area. Thank you so much, and thank you all for joining. Enjoy the rest of your evening, and we'll hopefully see you in February. Take good care.
Thank you all so much for coming, and thanks for having me.
Thank you.
Yes, thank you. It was great.
Thank you. Thank you. Glad you enjoyed it. You're welcome, everybody.